So the emphasis for today's video is going to be covering a progression of low back SI joint exercises that are predominantly given to the patient that comes in and expresses with low back pain that can either centralize their radicular symptoms to a specific point that they can actually kind of point at, and that definitely do present, as you see in the image, with a lower cross syndrome, which most of them will anyways. Not to say that all patients are very sedentary, but you can still be a very active individual with just very piss poor posture in sitting and in standing, with very bad biomechanics in terms of knowing how to load and unload the spine, which would lead to enough compensation to start to affect, as you see in this image, the knee joint, soreness in the foot, which is kind of why we call plantar fasciitis a junk term nowadays, because it could be coming from other areas, and as well shoulder-related dysfunction and or neck pain, cervicogenic headache type presentations, nonetheless though all being driven by poor posture. So the remainder of this video is going to cover some topics and some extremes to look at and to evaluate for, and then give you a progression of the exercises that I like to use to get that patient back to just being as confident and in control as they can of their own treatment, because that is ultimately the goal, is to be thinking of discharge from day one. Now, what we can say in general about most low back patients is a decreased ability to load any of the structures that are provoking their pain, either unilaterally or bilaterally, but that the pelvis plays a big role in influencing the movement of the low back, and the musculature that controls the pelvis oftentimes will present itself with compensation, trigger points, myofascial restrictions, and decreased ability to generate force due to decreased oxidative or non-oxidative capacities. Now let's take a look at the extremes of range of motion at the pelvic girdle that can lead to low back SI joint pain and maybe a presentable leg length discrepancy. So we know that we have a anterior pelvic tilt and a posterior pelvic tilt that, when excessively occurring, create these hyper and hypolordotic curvatures. Now, these excessive motions can definitely create havoc on the body's ability to produce force and reflexively activate our core and postural stabilizing muscles. Let's for a moment simplify what's happening and use the analogy of a house here to represent our abdominal postural stabilizing muscles. The roof would be made up of the diaphragm, the basement would be made up of the pelvic floor, and the walls would be made up of the various musculature of our anterior, lateral, and posterior musculature. Now, if we were to remove all the furniture from this home, i.e. our intestines and other various organs, we have a clear view now of the abdominal cavity. Now, those muscles that comprise of the entire abdominal cavity and pelvic floor and so forth really do generate their force through fluid dynamics or pressure, and it is this pressure that allows for the low back to receive most of its support. And again, we know that this pressure is what allows for those muscles to reflexively turn on and off when we change body positions. Hence, with excessive motion at the pelvis and these variations of movement along the low back, we can see that we can lose integrity of the ability to generate pressure, and hence lose the ability to generate proper force due to a decrease in the reflexive response of some of these muscles. Now, oftentimes the culprits that are presentable with an anterior tilt, often the iliopsoas and erector spinae, usually are very, very spastic And conversely, on a posteriorly tilted, we have a very tight hamstring and rectus abdominis. Both of these presentations oftentimes will have distinguishing remarks at what occurs at the knee and lower crural portion of the leg and foot. And this is kind of a chicken or egg scenario. Did the pronation of the foot create the valgus of the knee, which led to the anterior tilting of the pelvis, or did this occur from the pelvis and work its way down? And I often tend to believe most of the time the sedentariness and poor postural behaviors that originate in the low back and the pelvis are what do lead to some of the lower body mechanics, because when you do test out your knee patient that comes in and has very weak hip abductors, very weak hip extensors, overall poor squat mechanics, with a overhead position, looking at some FMS criteria, that knee and foot pain is really being driven from the pelvis itself. Now, what often occurs but maybe is overlooked are these asymmetries from left to right. These asymmetries or faulty movement patterns are a means of compensating for decreasing provocation. Ultimately, if we allow for these movement patterns to go on unhindered without any intervention, the normal occurrences of neuroplasticity occur, and all of a sudden, the individual now has a new movement pattern, although faulty. What we know is that over time, continuing to use a faulty movement pattern with poor success of achievement of the task, increased provocation of pain, tend to overstimulate the sensory input and can really lead to certain changes in behavior, can lead to anxiety and fear of specific movements and or activities. And this is where we start getting a little bit deeper into the pain science and fight or flight responses and neurochemistry changes, but that we'll leave for another video.
Let's get our patient with their feet on the wall and supine to assess for differences in pressure for asymmetrical rotations in the pelvis. The example here is the right leg felt like it had more pressure. Hence, the right leg expressed a posterior pelvic tilt. The next phase of this progression to seat the pelvis in neutral would be to then have them activate that right QL complex so that they can start to stimulate that GTO and bring down some of those spastic muscles. Once the patient is done performing those exercises, they'll reassess on the wall to make sure that there has been an improvement. Following this, we will now address the anteriorly rotated or shorter leg. What I like to do is have the individual perform a isometric or resisted hip flexion to help and again activate that GTO to relax that anterior tilt. When they're done, again they'll reassess on the wall. Following this exercise, I like to have them perform some isometric hip adduction to help to reset that anterior pubic symphysis where the two innominate bones articulate. Once the patient completes that, they will reassess on the wall. This next progression is just moving forward once they've established a more seated and neutral pelvis, so that they're using a host of hip adductors and abductors along with their glutes to work on some good motor pattern activation and as well pelvic floor activation. Sideline clamshells are an all-time favorite to help to recruit that hip external rotator and abductor. I like to use some lower quarter rotation to help to bring in a lot of just nervous system sensory information. Here's just a progression with dying bug, doing some alternating lower extremity marches. Of course, that TA is activated, same as they would do with their arms, and then progressing as well. Progression using a ball is often a good idea just because it adds a little bit of some resistance
and gives them something to hold on to and draw in the rest of the motor pattern chain of the upper extremity. Here are some Stort-McGill curl-ups using some breathing to aid in the postural activation of the rectus abdominis, and also with some hip extension to help to reciprocally inhibit the hip flexor. Again, here we just have some more of a progression from the dying bug, either bilateral upper extremity or bilateral lower extremity, shoulder or hip extension, doing some resistance with a ball. Here are some cat camel exercises that I like to use for some self-mobility of the upper thoracic spine, and again to just get some good sensory input into the nervous system from the lumbar, so we kind of decrease that sensation of threat with movement. Here just some starting arm marches, followed by a progression with the legs. Of course, you want to do this after they're centered. If not, you're just kind of working on the main issue. This is a little workaround. If it bugs your patient's wrist to be flat on the ground, you can use a dumbbell or a parallel bar. I like to do then some beginner bird dogs or quadruped, alternating upper and lower extremity with the pads. The cueing is to bring yourself up to the same level as the pad, and this is a great way to actually cue them to work those multifidi and the other of the posterior lumbar supporting postural muscles. Since we're using a big three method here, of course we got to throw in a lateral plank, bearing in mind any pre-existing shoulder conditions. But if all those things pass, I like to start off with a little bit of bolster underneath. Gives them some feedback as they feel the bolster kind of compress and decompress underneath them. And the progression would be to then remove the bolster and have them perform a standard side plank. Well, thank you guys for taking the time to watch this video. Go ahead and hit the like button if you like it. Leave any comments if you have any, and please subscribe to my channel. Take care and happy lifting.